Good evening and welcome to the National Pancreas Foundation 2021 Virtual Education Series. I'm Tricia O'Neill, the National Director of Chapter Development. The National Pancreas Foundation provides hope for those suffering from pancreatic cancer and pancreatitis through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Some of our featured programs include the Animated Pancreas Patient, state chapters that help boost education, fundraising, and patient support, and our Physicians Program, which includes research grants, medical education, and our annual Fellows Symposium. Our success depends on the support of many individuals and organizations. You can make a difference by joining a chapter, partnering with us by making a donation, coordinating a fundraiser in your community, or sharing your own personal story. For more information, please email us at info@pancreasfoundation.org. Our program this evening will focus on a healthy approach to diet and nutrition for pancreatic cancer and pancreatitis patients. We will learn how to take a healthy approach to diet and nutrition and view a short cooking demonstration of 2 recipes from the NPF cookbook. This short video includes some of NPF's volunteers and pancreas disease patients. Our featured speaker this evening is Dr. Anna Evans-Phillips, who is the Assistant Professor in the Department of Medicine, Division of Gastroenterology, Hepatology, and Nutrition at the University of Pittsburgh. She graduated from the University of Pittsburgh School of Medicine and completed training at Yale, Columbia, and the University of Pittsburgh for her residency, GI fellowship, and an additional medical pancreatology fellowship. She's the medical pancreatologist whose main research focus is on assessment and treatment of pain in chronic pancreatitis. She was awarded the Young Investigator in Pancreatitis Award in 2018 from the American Pancreatic Association. During the presentation tonight, you are welcome to submit questions to the Q&A section, and after the short cooking demonstration, Dr. Phillips will answer your questions. Welcome, Dr. Phillips.
Thank you. Thank you so much, Trish. And I wanted to specifically thank this evening Hatter Bursick, Trish O'Neill, Brooke Campbell, Sockball Toon, and the National Pancreas Foundation for giving me the opportunity to present this evening. And so, without further ado, again, my name is Dr. Anna Evans-Phillips. I'm an assistant professor of medicine at the University of Pittsburgh, and I'm a medical pancreatologist in adult and focused mainly on adult chronic pancreatitis. Tonight, I'm going to be discussing from that position a healthy approach to diet and nutrition to pancreatic disease, mainly focusing on those with chronic pancreatitis. I have no financial or ethical conflicts of interest to declare, but I do have one major caveat, and that is that underlying everything that I will present here is the fact that each person's nutritional situation is unique. And so this presentation does not replace any recommendations from physicians, nurses, dietitian, or nutritionists for any individual's unique situation. And I always recommend talking with a pancreatologist directly about any specific nutritional recommendations to optimize any individual's plan. And so in orientation for this evening's talk, we'll first talk about nutritional challenges in adult chronic pancreatitis. We'll talk about why this is important, why does malnutrition happen in chronic pancreatitis, the diagnosis of exocrine pancreatic insufficiency, the diagnosis of endocrine pancreatic insufficiency or diabetes, and then foundations of nutrition in adult chronic pancreatitis, including the tenets of a low-fat diet, pancreatic enzyme replacement therapy, nutritional supplements, vitamin supplements, and the overlap of these recommendations with those in pediatric chronic pancreatitis, post-pancreatic surgery, and pancreatic cancer. So first, nutritional challenges in adult chronic pancreatitis. Adult chronic pancreatitis is a fibroinflammatory disease of the pancreas, and it is a result of inflammation that does not heal or improve. It represents permanent damage to the pancreas, and this may manifest as chronic pain, or the inability of the pancreas to make digestive enzymes, or the failure of the pancreas to control blood glucose. There have been many interventions that have been recommended to alter the course of the disease. Frequently, and many of you have heard this over and over, is abstinence from alcohol, abstinence also from tobacco. Sometimes patients undergo endoscopic therapies, such as ERCP, in order to address strictures or stones or other pathology within the gland. Others may undergo surgery for similar indications. One thing that is becoming more apparent as we understand more chronic sequelae of the disease is that interventions from a nutritional standpoint can make a significant difference in people's quality of life and overall health over time. So why is malnutrition important in chronic pancreatitis? It can lead to sarcopenia, which is a syndrome describing the loss of skeletal muscle mass and the loss of strength in individuals. This can be associated with decreased quality of life, increased hospitalization rates, and overall decreased survival. Malnutrition also can result in vitamin and mineral deficiencies. And so these numbers are described based on a small study in Europe showing the prevalence of identified vitamin and mineral deficiencies in a small population of chronic pancreatitis patients. Interestingly, over 1/5 or over 20% of patients had evidence of vitamin D deficiency, 20% had evidence of zinc deficiency, 17% magnesium deficiency, 10% vitamin A deficiency, and 7% had vitamin E deficiency. And that's just in one small population. Now, there are many aspects of malnutrition in chronic pancreatitis, but some of the early signs that can be seen, or the most obvious signs, can be unintended weight loss or the maintenance of an underweight status, vitamin and mineral deficiencies, as I mentioned above, and then things like mineral bone disorders that are quieter but can be just as detrimental later on, including things like osteopenia and osteoporosis. But there are many factors that contribute to underweight and malnutrition in chronic pancreatitis. But the basic equation, just like in any discussion about weight, is a matter of calories in versus calories out. Now, for many chronic pancreatitis patients, there are numerous limitations to their ability to intake adequate calories. Those limitations might include things like postprandial pain or pain that happens after eating. Patients can develop a fear of eating. In some patients, they've experienced the phenomenon where eating can actually be a trigger for an acute on-chronic pancreatitis attack and can be particularly traumatic. Other patients may suffer from chronic nausea and be unwilling to eat. Now, the other way that one can have a deficiency in calories is, of course, losing calories. And so for some patients, that happens in the setting of vomiting, if they are having nausea and vomiting after eating. And then also in a condition called steatorrhea or fatty diarrhea, where patients may develop chronic oily diarrhea, which represents a phenomenon secondary to malabsorption, and they may lose calories that way, resulting in weight loss. Now, the pancreas has two major functions. That includes the exocrine function of the pancreas, and this is where the pancreas creates digestive enzymes that break down protein and fat, and the endocrine function of the pancreas, where the pancreas makes insulin, glucagon, and other hormones that regulate blood glucose levels. The loss of pancreatic function can occur secondary to pancreatic damage. Now, damage to the pancreas itself can occur gradually after multiple episodes of acute inflammation, such as occurs in acute pancreatitis, or quickly after a very severe episode of inflammation, such as occurs in severe acute pancreatitis, following surgery, where parts of the pancreas may be removed, such as people may experience for cysts of the pancreas or tumors of the pancreas, and other patients undergo complete removal of the pancreas, such as in total pancreatectomy, in an effort to treat pain from chronic pancreatitis or for other indications. And so as a consequence of the scarring, destruction, or surgical removal where all or part of the pancreas is taken away, the pancreas can lose the ability to perform one or both of those functions. So we'll start by talking actually about pancreatic exocrine dysfunction. The pancreas has a very large secretory capacity. It makes up to between 1.5 and 2 liters per day of fluid, mainly in the form of digestive enzymes. This is a combination of sodium bicarbonate and then enzymes to digest fat and protein, including amylase, lipase, and protease. Individuals who lose the exocrine capability of their pancreas may have difficulty digesting and absorbing fat and protein. You may have heard of a syndrome called exocrine pancreatic insufficiency, or EPI, which is a syndrome that occurs secondary to the loss of the ability of the pancreas to digest fat and protein. Now, exocrine pancreatic insufficiency has been most completely described in late-stage chronic pancreatitis, where over 90% of the pancreatic tissue has been destroyed. The degree of dysfunction, though, of the pancreatic exocrine function parallels actually the degree of fibrosis or destruction in the pancreas. And so we actually have very limited tools to assess exocrine pancreatic insufficiency before it gets all the way to that late stage. And so patients may gradually manifest some of these symptoms over time as their pancreas becomes more and more damaged. And in a stepwise fashion, they may see some before others, but the manifestations might include weight loss, steatorrhea, or that fatty diarrhea that I mentioned, or fat-soluble vitamin deficiencies. Now, the treatment for exocrine pancreatic insufficiency is pancreatic enzyme supplementation, which we'll talk about a little later. Vitamin and mineral deficiency is another aspect of exocrine pancreatic insufficiency. It's important to remember that fat-soluble vitamins are just that. They are soluble in fat, and they actually must be accompanied by digested fat in order to be absorbed. Low levels of fat-soluble vitamins and minerals can lead to further complications that are easily avoidable with adequate supplementation. And so as a medical pancreatologist for adults, I tend to recommend annual monitoring of these levels and then subsequently commencing supplementation in the setting of any detected deficiencies. Now, these are some of the examples of symptoms that people can have when they manifest with vitamin or mineral deficiencies that are specific. So in vitamin A deficiency, people may develop symptoms of night blindness. Vitamin D deficiency can lead to symptoms of osteopenia or osteoporosis. Vitamin K deficiency, people can have bleeding complications. And in any of vitamin B12, zinc, or copper deficiencies, people can develop signs of anemia. Now, moving to pancreatic endocrine insufficiency, this is a condition also widely known as diabetes. As you can imagine, a new diagnosis of diabetes for any patient with pancreatitis further complicates their nutritional goals. In this situation, it's often advisable for pancreatitis patients to establish care with an endocrinologist, as pancreatitis and concomitant diabetes can be very challenging to manage. Endocrine dysfunction or diabetes related to the pancreas is also called type 3C diabetes or pancreatogenic diabetes. You may have heard it referred to with any of these names. Now, the prevalence of this type of diabetes varies widely. Estimates are between 25 and 80% of chronic pancreatitis, but it's important to note that the increased incidence actually occurs more commonly with increased duration of disease. In other words, the longer that someone has chronic pancreatitis, the more likely it is that they will develop diabetes over time. To date, there has been no universally accepted diagnostic criteria for this phenomenon, but there have been criteria proposed, including patients who have concomitant exocrine pancreatic insufficiency, patients who have diabetes and evidence of pancreatic abnormalities on imaging, and then also patients with diabetes who have an absence of the related autoimmune markers for type 1 diabetes. Now, in pancreatic endocrine dysfunction, the thought is that there is inadequate insulin produced by the islet cells in the pancreas. Most frequently, we think this is due to destruction of the pancreas or resection or removal, rather, of parts of the pancreas. This is different than in type 2 diabetes, where you may have inadequate insulin circulating as cells develop resistance to insulin. There's also believed to be a possible immune component, though, to pancreatogenic diabetes, and this is less well understood. I'd like to reassure you, though, that there is extensive ongoing research on this topic, and you may be hearing of future opportunities to be able to participate in regarding this particular subject as relates to pancreatitis. And so with that, I'll move to the second portion of the discussion tonight, which is actually on foundations of nutrition in adult chronic pancreatitis. One of the major cornerstones of nutrition in chronic pancreatitis is the avoidance of both alcohol and tobacco in pancreas disease. And this is actually in patients for whom alcohol and tobacco have been a risk factor, and in those in whom it has not been a risk factor. We know, of course, that alcohol is an independent risk factor for chronic pancreatitis, and many patients know this all too well since they're asked about it very frequently. Some patients are not also aware that tobacco is actually also an independent and a dose-dependent risk factor for chronic pancreatitis. It's thought that tobacco smoking alone attributes up to 25% of the risk for chronic pancreatitis. And we know that the effects of smoking are stronger in alcohol-related chronic pancreatitis. Now, if we take a step back, acute pancreatitis, which is much more frequent than chronic pancreatitis, at least 4% of all patients with acute pancreatitis will go on to develop chronic pancreatitis. It's also known, though, that in alcoholic acute pancreatitis, rates are higher for progression, and estimates vary widely, but after 2 years, estimates range from somewhere between 13 to 90% of patients in alcoholic acute pancreatitis will progress to chronic. And after 10 years, this narrows somewhat, but the estimate may range from 16 to 66%. It's known that continued alcohol use and tobacco use will hasten progression when used together. Now, moving to a low-fat diet, this is one of the other tenets of nutrition in chronic pancreatitis that patients hear a lot about. Now, with regard to a low-fat diet, I want to start out with a little bit of the idea behind why a low-fat diet is useful in chronic pancreatitis. Fat-containing foods in the stomach, fat that you have eaten, triggers the pancreas to secrete digestive enzymes. And so foods that are rich in fat, anything that contains oil, butter, cheese, cream, lard, can cause episodes of pain for some people. These fat-containing foods can trigger an episode of acute pancreatitis if the pancreatic enzymes that are secreted in such a fashion that they cause inflammation in the pancreas or inflammation in the surrounding structures. And so for this reason, there's a large emphasis on maintaining a low-fat diet for most pancreatic experts in order to reduce the chances that any pancreatic enzymes that are secreted will cause further inflammation. It should be acknowledged, though, that there are many limitations of a low-fat diet. And so, by design, it decreases pancreatic enzyme secretion, but it also then renders any endogenously secreted lipase unstable in the intestine since it doesn't have much to work on. A low-fat diet also results in less effective use then of pancreatic enzyme replacement therapy. Pancreatic enzyme replacement therapy is designed to break down fat and therefore help absorb fat-soluble vitamins and other nutrients. And if it doesn't have any fat to work on, it may be rendered less useful. A low-fat diet can also mask the onset of exocrine pancreatic insufficiency, sometimes delaying the diagnosis and other times making the diagnosis difficult. Also, fat is not the only macronutrient that is malabsorbed. People have difficulty digesting protein and carbohydrates as well. And so Those limitations need to be kept in mind as the low-fat diet is recommended or adhered to by patients. Now, the ideal diet in pancreatic disease of any kind is delicious, nutritious, non-harmful, and feasible. And there are a lot of things that are meant by that. And so starting with fat content in diet, which can contribute to the delicious nature of any diet, patients actually may be able to tolerate up to 30 to 33% of their daily calorie intake from fat. Now, the US Dietary Guidelines for Healthy Adults suggests the following calorie breakdown: that 45 to 65% of your daily calories should come from carbohydrates, 20 to 35% from fat, and 10 to 35% from protein. Those can be modified for any particular individual, and oftentimes nutritional goals are complex. They may be related to weight loss or weight gain. They may be related to food likes or dislikes, particular triggers for pancreatitis, and so all those things need to be kept in mind. But that is diet as relates specifically to fat content. And so the next portion, nutritious, I wanted to talk about pancreatic enzyme replacement therapy, since that is a major contributor to absorption in exocrine pancreatic insufficiency in chronic pancreatitis. So pancreatic enzyme replacement therapy, or PERT for short, is often prescribed to patients with exocrine pancreatic insufficiency to specifically assist with the digestion of fat, protein, and absorption of all of the previously discussed vitamins and minerals. You must remember that pancreatic enzymes do not treat the pancreas. Pancreatic enzymes treat the food that is eaten so that way it may be adequately absorbed. Now, PERT therapy is given specifically with the intent of accompanying a nutritious diet. The enzyme capsules themselves need to travel through the intestines with the food, and they assist then with the timely breakdown of the food as the combination arrives together at the areas of the intestine where specific vitamins, minerals, and nutrients are absorbed. I get a lot of questions about pancreatic enzyme replacement therapy. First and foremost, what is it? It is porcine-derived lipases, proteases, and amylases that are placed into small capsules. Now over here on the right, what you see is a chart actually of FDA-approved formulations of pancreatic enzyme replacement therapy as of 2013. There are multiple brands, and what you see are the dosages available for each brand, the manufacturer, approximate cost at that time per 10,000 units of lipase. Now they can be broken down into several categories. Of them, the oral delayed release capsules include the following, and these are included within an enteric coated capsule, essentially designed to make it through the stomach and then release enzymes farther down in the intestine once gastric acid has had a chance to work on the capsule to release the enzymes again farther down in the intestines. There's a brand called Pertsy that actually contains bicarbonate buffered enteric coated microspheres and as an additional design component, essentially designed to help neutralize stomach acid and again, release the enzymes at a certain place in the intestines farther away from the stomach where some of the nutrients can start to be absorbed. There is also an option in a non-enteric coated tablet. Some patients find that the enteric coating is problematic for them with regard to timing of enzyme release. And so this particular non-enteric coated tablet just notably needs to be taken in combination with an acid suppression medication in order to prevent the medication from actually breaking down in the stomach and digesting everything there. Dosing of pancreatic enzymes is always measured in lipase units, which can be confusing for patients, but you'll see that most capsules have a listing of lipase amounts, protease amounts, and amylase amounts. The minimum appropriate dose for patients is 500 lipase units per kilogram per meal. Now, in a 60 kilogram person, what that would translate to actually is 500 lipase units times 60 kilograms equals a minimum of 30,000 lipase units per meal. Now, most frequently, many pancreatologists will prescribe over 40,000 units per meal in order to meet at least this minimum dosing and go above that. The ideal is that patients can adjust their dosing according to their symptom needs. The first capsule of pancreatic enzymes, no matter the dose, should be taken with the first bite of each meal in order to ensure that enzymes accompany that food throughout the intestines. And then any additional capsules can be timed accordingly during the meal. Again, the dose can be increased to a level needed to treat any symptoms that patients are having of exocrine pancreatic insufficiency. And the exact dosing, in order to ensure adequate supplementation, should often be discussed with a GI specialist or a pancreatic specialist. Now, the effects of adequate pancreatic enzyme supplementation are to improve the absorption of fat, protein, carbohydrates, vitamins, and minerals. In some patients who have a lot of gaseous distension of the intestines in the setting of malabsorption, it can also potentially help with pain from that side effect of malabsorption, though the capsules themselves are not designed to treat pancreas-related pain. The side effects of pancreas enzyme replacements are very rare, but they include fibrosing colonopathy, a very rare side effect that has been described with large doses traveling quickly through the intestines, mainly in children, and then they open in the colon where they release all of the enzymes in one location. Very rarely, people can have a true pork allergy. And if there is such a concern, it's recommended to discuss this with an allergist to see if there may be potential situations in which enzymes can still be taken. And then in some patients who have baseline increased uric acid levels, it can further increase uric acid levels in the bloodstream and has been described to induce gout attacks in some patients who have baseline risk for gout. Now, sometimes with nutrition in chronic pancreatitis, there are very extenuating circumstances where patients cannot tolerate oral nutrition. And in these situations, there are several other possibilities that exist, so I want to mention those since some patients may have experienced this. Enteral nutrition, where nutrition is delivered through a nasogastric or a nasojejunal tube. And in this situation, we've often seen the use these days of a hydrolyzed lipase cartridge, which can be used in conjunction with the enteral tube to help break down enteral feeding to make it more digestible and assist with fat-soluble vitamin absorption. Some patients who cannot also tolerate enteral nutrition may be, in rare circumstances, treated with total parenteral nutrition or IV nutrition. But in general, this is to be avoided if possible, and enteral feeding is preferred to TPN. It's been shown in many studies actually to better maintain the intestinal barrier from infections, reduce organ failure in severe acute pancreatitis, eliminate central line infections, and reduce infectious morbidity and hospital length of stay in patients specifically with severe acute pancreatitis. Now, this schematic on the right shows just a diagram essentially of several of these routes of nutrition, of alternative nutrition, just to get an idea of what they are. Now, the nasogastric tube, of course, goes through the nose, and then you can see it terminates in the stomach, starting in the upper right-hand corner. And then from there, you can see there's a gastrostomy tube, which otherwise is sometimes known as a PEG tube. This goes through the abdominal wall directly into the stomach. And a jejunostomy goes directly through the abdominal wall into the small intestine. Now, both nasoduodenal and nasojejunal tubes go through the nose and then down into different portions of the intestine accordingly. And then in this upper left-hand corner, you can see intravenous nutrition through the peripheral veins is peripheral parenteral nutrition, or PPN. That delivers only a very small portion of necessary nutrients, and so we generally steer clear of that. And TPN, or total parenteral nutrition, you can see is delivered into the central veins. And again, that's to be avoided unless there are very extreme circumstances. And so moving on to nutritional supplements, that's something that we talk about a lot, actually. Now, nutritional supplements may be useful. They may be high in protein and they may be high in calories, which achieves several of the goals, but they also may be high in fat. And so for patients who are trying to avoid fat content in their diet, many of them may not be appropriate. And so lastly, but perhaps importantly, they may be nutritious, but many of them may not be delicious. And so this is an example of some of the items we have on formulary at our hospital. And this runs the gamut, actually, from rehydration solutions to protein supplements to meal replacement supplements and other protein and calorie supplements. Others are natural food supplements. And again, each may have their place. Oftentimes, I recommend discussing again with their GI specialist or pancreas specialist which items may be of particular use in any individual situation. But these are options actually in order to achieve nutritional goals, especially during certain periods of higher acuity for patients when they can't take adequate nutrition. Other adjunctive therapies that are asked about frequently include probiotics. Now there is no general recommendation that can be made for their routine use in chronic pancreatitis. Unfortunately, these are not FDA regulated, and so many patients find them very useful. However, there's high variability both between and within product lines, and so it's not something that we're able to routinely recommend for patients accordingly. Minerals, as I discussed earlier, patients can often be deficient in. However, because of potential toxicity with oversupplementation, it's important to review this with your medical care provider before starting any course of supplementation. With antioxidants, again, some patients may find these very helpful. Some studies have shown a mild benefit actually in pain for patients with painful chronic pancreatitis, but it's been a mild benefit. And so again, it's on a patient-by-patient recommendation basis that we do these. Wanted to make sure to touch on a high fiber diet because this is often something that is recommended as a generally healthy aspect of diets for people who are trying to eat healthfully. Now in chronic pancreatitis though, especially when patients have exocrine pancreatic insufficiency, it's not altogether straightforward. And truthfully, a high fiber diet is not overly recommended in chronic pancreatitis with EPI. Both the soluble and insoluble forms may actually inhibit the activity of secreted pancreatic lipase. So for those patients who still do make some pancreatic lipase, this can actually intensify symptoms of fecal fat excretion and sometimes even worsen exocrine pancreatic insufficiency. The message, therefore, is that a moderate amount of fiber is useful, certainly for bulking stool, for bowel habits, and for maintaining general health. However, too much emphasis on a high fiber diet may actually be not detrimental, but potentially a downside for patients specifically with EPI. With regard to vitamin supplementation, a general multivitamin is often recommended to ensure that there are baseline stores of very common vitamins and minerals. In patients who have fat-soluble vitamin deficiencies, fat-soluble vitamin supplementation can be pursued, but again, it's recommended actually that this be a targeted supplementation in patients who have specific fat-soluble vitamin deficiencies in order to avoid toxicity with any vitamin in particular. I wanted to touch briefly just on pediatric recommendations and how those may differ slightly from the adult recommendations. And so The macronutrient distribution for healthy children ages 4 to 18, and specifically then also in patients with chronic pancreatitis in that age group, is the following breakdown, and is similar to adults, with carbohydrates being recommended to be 45 to 60% of calorie intake, protein 10 to 30%, and fat 25 to 35%. Now, children who have cystic fibrosis and pancreatitis related to this may actually require a much higher fat diet, even over 35% of their calories daily from fat. In children with chronic pancreatitis, the normal fat diet, as mentioned above, is actually what is recommended, unless there's a concern that high triglyceride levels or hypertriglyceridemia is the cause of their pancreatitis. And in all children, actually, because the macronutrient distribution is so important for growth and development, it's recommended actually to discuss specific nutritional goals with a pediatric pancreatologist. In pediatrics also, enzyme supplementation guidelines have been written for providers who are interested in following and adjusting enzyme replacement according to standardized guidelines. And so there are several different techniques that can be used, but again, these can be discussed with a GI specialist or pancreatic specialist locally. But one last note on pancreatic cancer. It's important to acknowledge that a lot less is known about management of diet as a way to either impact or prevent pancreatic cancer. But we do know that both diabetes mellitus and obesity are independent risk factors for pancreatic cancer. And so lifelong, a healthy diet and maintaining a healthy weight are important health choices that can be made to try and reduce that risk over a lifetime. A varied diet that is rich in vitamins and minerals and adequate in calories is always recommended for those with a new diagnosis of pancreatic cancer in order to establish the nutritional stores that people need in order to go through the recommended treatments. Now, post-surgery, especially if patients go through surgery for a pancreatic cancer, many of the discussed recommendations for chronic pancreatitis may apply since part of the pancreas will have been removed. And so that brings me to the end of the material for this presentation, but I wanted to mention a few very patient-friendly resources, including the National Pancreas Foundation cookbook. You can see here the online link for that cookbook. Accompanying that is actually a pocket guide, which can help patients to navigate food choices in grocery stores and in restaurants if you're eating out. The U.S. Dietary Guidelines show some basic tenets of healthy eating for all adults. And then the Cystic Fibrosis Foundation has some very helpful material actually for both adults and children affected with cystic fibrosis. And so with that, I'd like to thank everyone for attending this evening, and again, the National Pancreas Foundation for giving me the opportunity to present this information. I'll be happy to take questions during the question and answer session a little later, and I'd like to pass it back over to Trish O'Neill.
Thank you so much, Dr. Phillips. Next up, we will have a short presentation of quick, simple, and healthy recipes from our NPF cookbook that you can view online. And as Dr. Phillips mentioned, you can also order a hard copy from our website at pancreasfoundation.org. And after the short video, Dr. Phillips will take a few minutes to answer your questions.
Hi, my name is Cecilia Petricone, and today I'm going to be cooking one of the recipes from the NPF cookbook. I'm going to be making a spinach and cheese frittata, which I'll show you all of my steps in just a second. But first, I just wanted to introduce myself. Like I said, my name is Cecilia. I'm 23, and I currently live in Boston. I'll be graduating from college in May, but I became connected with the NPF after I spent most of my teenage and early adult years battling chronic genetic pancreatitis. And in 2018, I went to the University of Minnesota and had a TPIAT, which was really successful. Now I live with no pain. I take insulin to supplement the insulin that my cells make naturally and enzymes to eat. But I'm really excited to cook this recipe today. I chose this one because I'm a pescatarian, so I don't eat like most animals, I only eat fish. So this is a really yummy looking recipe. Spinach and cheese frittata. It has like onion and garlic. So yeah, I'll take you along while I cook. Alright, so as you can see here, the onions are really cooking down, like they're getting kind of caramelized. I'll probably need like another minute or two. But while this sets, I'm going to, I really lightly buttered this 9x9 baking sheet, and I preheated the oven to 350. So I'm gonna put this in to start heating it up. So the onions are set aside and cooling. They've gotten nice and caramelized. So while that cools, I'm gonna come over here and mix together the remaining ingredients. So in this bowl, there is 6 whole eggs, and then the equivalent of 10 egg whites, but I used liquid just because it was easier and I didn't want to waste the yolks. So I'm gonna put in, I already pre-measured, this is 2 like tightly packed cups of spinach. So that's gonna go in. And then here we have a 1/2 cup of feta cheese. You might notice I put a little bit less than a 1/2 cup, and it's because I want to save a little bit to just put on top at the end. And then I just have my salt and pepper that I already pre-measured in this little cup. So I'm gonna put that in. I'm gonna stir all of this around and really get it well integrated. And then in a couple minutes, once the like onions and the garlic have cooled a bit more, just so they don't cook the egg, I'm gonna mix that in as well. All right, so it's been a bit, and our like onion and garlic mixture that's all like caramelized and way cooked down now has cooled. So I'm gonna add that to our like spinach, egg, and feta cheese mixture we already have, and mix this in as well. And as soon as I'm done mixing this, the pan that I put in the oven earlier should be ready to go. So it just needed to be like pre-warmed. So I'm gonna pull that out in just a second, and then we'll pour this in there as well. All right, so our lightly buttered baking pan is hot and ready. So I'm just going to add in our whole mixture. I'm trying to spread it out so that our onions and our garlic get everywhere evenly. I believe they did. I'm just gonna grab an oven mitt, and we're gonna put it back in for, I know like the maximum is about 20, so I think I'm gonna check it in like 10 or 15 just to see how it's looking. All right, into the oven, we're still at 350. All right, so it's been about 20 minutes and I just took it out and it's looking great. It's fully set. Like I mentioned earlier, I saved a little bit of feta cheese to just sprinkle on the top at the end. And yeah, it looks really good, and I'm excited that I have breakfast for the whole week now.
Hi, my name is Cece Tower. I am a chronic pancreatitis patient. I had my TPIT surgery just over a year ago, and today I'm going to be showing you how to make a strawberry lemon smoothie from the Healthy Family Cookbook for Pancreas Disease patients. And this recipe is super delicious and easy, quick to make. You don't need a ton of ingredients or have a ton of skill to make it. I love having it in between my classes if I don't have a ton of time to make something, or right before my 8 a.m. to tide me over so I can make a full breakfast. It's super fast, delicious. You're gonna love it. Enjoy.
Wonderful. Thank you so much. I wanted to also thank those presenters. That's wonderful. What great videos, and yeah, the recipes look fantastic. And so thank you so much. So just in answer to a few of the questions, we've got a few minutes remaining here. We received a question about whether non-enteric coated medications such as Viacase and their effectiveness, whether they may be more effective than Creon or one of the other enteric coated medications. Every patient situation is different. And so I think the important thing to remember is that if you have attempted treatment with one type of pancreatic enzyme replacement therapy, and there are issues with it, intolerance or a lack of efficacy, know that there are other types of pancreatic enzyme replacements that can always be tried in its stead. Oftentimes patients may have some trouble getting these medications covered by insurance, and many of the companies actually have programs to try and provide medications to patients on a trial basis. And so important to talk with your pancreatologist about those opportunities as they're available. Another question that was asked actually is about the testing for exocrine pancreatic insufficiency and when someone gets started on pancreatic enzyme replacements. Testing for pancreatic enzyme or pancreatic exocrine insufficiency has been historically very challenging, and there are limitations to several different types of testing that can be offered for exocrine pancreatic insufficiency diagnosis. Sometimes patients develop symptoms that are very clear to their provider, and they may be started on enzyme replacement as directed therapy. Other times, patients may undergo stool testing for a component called fecal elastase 1. And this is a stool test which is looking at the quantity of a certain digestive enzyme produced by the pancreas. There are limitations to this test, but this is a frequently used test by pancreatologists to make the diagnosis prior to starting and then directing enzyme replacement therapy as a result. That's something, again, that you could talk with your GI physician, primary care doctor, or pancreatologist about. Now, Jennifer asked, how is chronic pancreatitis detected? This gets at a very important point, and that is that there is not a universal diagnosis for chronic pancreatitis. There has been a very careful set of definitions that have created a consensus diagnosis for chronic pancreatitis. And so pancreas experts across the world have worked for years actually to agree upon what defines chronic pancreatitis. I think there are often several things that are considered to be unmistakable in chronic pancreatitis, and that is evidence of calcium deposits within the pancreas, evidence of diabetes secondary to atrophy of the gland, and evidence of malabsorption related also to pancreatic dysfunction. Some of the other questions actually were about pancreatitis in different age groups, because the causes of pancreatitis in pediatric patients as compared to adult patients can be quite different. And so in adults, we know that some of the most common causes actually are toxicity from alcohol and tobacco, or episodes of recurrent acute pancreatitis secondary to many other causes. However, in children, oftentimes there may be an underlying genetic cause. And so the recommendation actually from me would be to talk again with your local gastroenterologist or pancreatologist about potential testing for reasons if patients are diagnosed with acute pancreatitis at a young age. Now, some of the other questions actually were about elevations of lipase level in blood testing. And In a patient with an elevated lipase level, I think the recommendation would be actually to talk with their primary or gastroenterologist about what the lipase level interpretation would be. Sometimes that can be indicative of pancreatitis, and other times that may be elevated for other reasons. And so any dietary recommendations related to a blood test result like that should actually be related to what the underlying diagnosis might be. One of the other questions is about a diagnosis of chronic pancreatitis related to a mutation in a cystic fibrosis gene. And this is a unique situation in some ways because it's a very specialized situation within all the diagnostic possibilities of chronic pancreatitis. But there are many tenets, I think, that could be followed or gone through in this well-described situation. And so if that is the case, I think talking with a pancreatologist about the things that someone would be at increased risk for with regard to cystic fibrosis that is underlying, meeting with a local cystic fibrosis center at a pulmonology, in a pulmonology department, and then also trying to meet with a pancreatologist who may be part of one of the National Pancreas Foundation Centers of Excellence may be one of the ways actually that you could start to educate yourself about what kinds of things to look for or follow up about. Those centers have been evaluated by the National Pancreas Foundation as places where there's a lot of academic work going on and a lot of discussion kind of on the cutting edge of academic research. So that's something that would also be recommended. Someone asked actually about, let's see, about whether a calcium deposit in the pancreas is the same thing as something they've been told is, quote, scare tissue. And to be perfectly frank, I've not heard that term before. And so that's something that actually I would further clarify with the provider with whom you might have had that conversation. Others have asked about specific dosing of pancreatic enzyme replacements, specific numbers of lipase units, and also what happens when you take too much enzymes and what happens to that's not used up in digestion. And so with regard to specific dosing, there's still a lot of work to be done on the exact science of lipase unit dosing for pancreatic enzymes. Each patient is a little bit different in terms of how many lipase units they may require, and that depends on many things. It depends on the exact absorption environment of your intestinal tract. It depends on how much native or endogenous lipase your own pancreas may make and help to digest things that you eat. And so working with your provider actually to pinpoint the exact dosing is the best suggestion that I can make. In general, the teaching is to take pancreas enzymes whenever you do eat essentially anything. The idea is that those enzymes that you take by mouth can accompany the food and then travel with that through the intestines in order to assist with absorption. With regard to enzymes that may not be used in digestion, the thought is that those generally travel through but do not have any ill effect on the rest of the intestines. I think ideally you would take just as many enzymes as you need and not more than that in order to absorb the food that you eat. So one of the other questions actually was about any water recommendations for chronic pancreatitis management. And that's a great question. I think similar to any other illness where nutrition is an underlying issue, it's important to maintain good hydration. Dehydration alone does not tend to have an impact day to day on the pancreas directly. However, in the setting of an acute flare, dehydration, broadly speaking, may actually be construed as having a more severe result in that acute flare and in perpetuating inflammation than patients who are better hydrated during an acute flare. In general, I would say somewhere between 2 and 4 liters of water per day for adequate hydration would be recommended. Someone else asked a question not directly related to nutrition, but about pain in chronic pancreatitis and whether it's possible for patients to have pain in chronic pancreatitis despite a lack of testing that might show evidence of an acute attack. And yes, absolutely. Abdominal pain in chronic pancreatitis is the most common manifestation of the disease, actually. And between 80 and 90% of patients with chronic pancreatitis perceive pain at some point during their disease course. Certainly, it's possible for patients to have flares of pain for many reasons, even outside of flares of acute pancreatitis. So there are some other questions actually about management of acute on chronic pancreatitis and specific complications of acute pancreatitis as relates to progression or management of the disease overall. And so essentially the way I would answer Katya's question about whether recurrent acute pancreatitis can progress with or despite lots of interventions. Indeed, patients with recurrent episodes of acute pancreatitis or inflammation can progress over time to have scarring in their pancreas that can become chronic. And so, again, every individual patient is different in the natural history of their progression, but certainly that is well described. And then a more recent question actually asks about frequency of attacks and the manifestation then of weight loss with each of these attacks coming so frequently. In terms of management of those attacks or ways to prevent recurrent attacks, again, that's something that would need to be discussed directly with a pancreatic provider in order to know what the likely cause is of those recurrent attacks and be able to assist both with nutritional supplementation as well as a way to treat the ongoing inflammation. Great. We had another question actually about whether patients need to limit sugar intake, similar to fat and protein and carbohydrates. Now, sugar actually would be included within carbohydrates as a simple carbohydrate. And so in the subset of patients who develop diabetes related to their chronic pancreatitis, yes, definitely, it's important to monitor sugar intake very carefully. With regard to the ideal breakdown of fat, protein, and carbohydrates, simple carbohydrates may be a useful energy source for people who are unable to take in more complex things due to symptoms of malabsorption. But simple carbohydrates, in other words, sugar alone, should not be the only source of carbohydrates to maintain a varied, healthy diet. And so, similar to any well-balanced diet, sugar intake would be limited in chronic pancreatitis in the same fashion, especially if it's independent of diabetes. Great. Well, I think this evening we have time for one last question, if anyone has any additional questions. But if not, then I would again just like to thank Trish and the National Pancreas Foundation and to all of you actually for participating this evening.
Thank you so much, Dr. Phillips, and for everyone for joining us. We hope you'll please follow us on Twitter, Facebook, and Instagram to learn more about our upcoming education and fundraising and patient support opportunities. Thank you all and have a great evening.